Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
For this Monday. First one is one that kind of is implied by all we do every week. It talks about the tweaks that have a big effect on your lifespan. The three habits that matter the most in terms of how long you live and the quality of the life that you live. First is the amount of sleep that you have, the amount of physical activity, and not surprisingly, the food that you eat uh, or don't eat, whichever way you want to look at it. And one of the things that they identified is that there's an ideal mix of how long you should sleep and how long you should what you should eat and how long you should exercise. And so they identified the ideal mix as being sleeping at least 7.2 hours a night, have at least 40 minutes of physical activity, and uh, high quality diet with the predominance of vegetables and fruits. And that would give you an additional 10 years of life, uh, which I think anybody would want additional 10 years of quality life. Uh, and they also added that if people would just add, if they aren't at those levels, would just increase uh, what they're doing by maybe 1 or 2 minutes, 5 minutes of extra sleep, uh, about 10 minutes of physical activity, and uh, more fruits and vegetables, that they would uh, improve their longevity and the quality of their lives that they live. And so this is a very simple article talking about small, relatively small changes that could conceivably add 8 to 10 years to your life. So I thought that was very interesting. Any comments on that combination of small changes that could add years to your life?
Dr. Callender, good morning again, everyone. Did you say 40 hours of exercise?
40, yeah, 40, did I say 42 minutes? Yeah,
42
not
minutes.
hours. Yeah,
Okay,
yeah,
good. I'm glad
a
it's not
day.
hours.
Right.
Thank you.
Okay, the no comments on that because I think we all know most of that already anyway. This second article that I found was of great interest was an article that talks about those of us who travel, go long distances. One of the problems that we notice is that a lot of times you get what they call traveler's diarrhea. And what the article talks about is that this is actually treatable by a very simple medication, and that's Pepto-Bismol, which most of us have access to. It's very inexpensive, but it's something that goes a long way to take care of traveler's diarrhea. But there are other things that you can do as well. Uh, One is you could be careful about the restaurants you choose to eat at, and It suggests that you eat at busy restaurants and at times when the locals eat. It it recommends avoiding buffets because the food sits out for long periods of times and is touched by many people. Um, Drink water that comes from a bottle whose seal you broke and skip the ice they suggest. And choose fruits you peel yourself. Approach salads with suspicion and skip the tabletop sauces. That sauces kept at room temperature contain high levels of bacteria. So those are some of the little tips for those who travel a lot and want to avoid that so-called traveler's diarrhea. Any comments or questions about Dr. Perez?
I was really going to wait until anybody else had any questions on that because mine is kind of going back to the last article. So I'll wait.
Oh, you had a question about the last article? What about it?
We all know it about the food, about the exercise, and about the sleep. But we as a community are still not doing very well with it. And this article talks about the practical things that we can do. One that is very important is that we can hear it over and over and over again and then do it. And the other things, though, I think that we need to do. I know our students, our young people who are laying down habits under many pressures to find a job, keep a job, do well in school, and then still be young. So how many of them are getting 7 to 8 hours of sleep? What and that's where I laid down bad habits for decades. We women, no, we women. What I when I went to bed, my mother was up. When I got up, my mother was up. I didn't see her prepare to go to bed. What are we doing as a collective group while our community is being oppressed to make sure that these habits are ingrained in our life?
Good question. I don't know because it's one thing to preach something; it's another thing to practice it, and that's where the problem lies. And that we sometimes we talk a good game, but we don't actually practice what we preach, and so that's a problem. I think you hit the nail on the head, and thanks for your comments, John Buchanan.
Yes, good morning, everyone. Traveling long distances, especially flights, I found the opposite happens. I get constipated. So I take Metamucil when I travel. I take an extra dose, and that keeps me regular. I still have my bottle of Pepto-Bismol, though, just in case. Every time I travel, I have to take that just in case. Because the food in some of these foreign countries might disagree with me, but definitely, it seems sometimes the road trips also on the highway, long distances can pack my system down. So I use a loosener. It's the opposite of what the article was talking about.
Thanks for sharing, Darryl.
Yeah, about the traveler's diarrhea. Usually it comes from contaminated water or food, from bacteria. And some of the nastiest things in any restaurant are ice and the fruits that they put in your drinks, the lemon and lime. So, just try to avoid that. I know you like the taste of a cold drink, but if you can manage to drink it without ice, it's a lot safer.
Thank you for sharing. Any other comments? The last article that I thought was worthy of talking about was allergy system is coming up. It's not here yet, I guess, but it's on the way. It'll be here any minute. As soon as this cold weather stops, we'll be in the so-called allergy season.
It's here
And they
now.
talk, yeah, well, yeah, you're right, but usually when it's as cold as it is now, you don't always see the effects of it. And they say that about 80 million Americans have seasonal allergic rhinitis, which uh, we all know about. And so he recommends about 5, 6 different things that you might do. And he says from the get-go, have all of your allergy medications in your medication cabinet so you don't have to go to the drugstore. Have your antihistamines and nasal sprays and your eye drops and all of those things ready. And then he's this actually it's a lady who suggests that you start your medications uh, as early as you can to don't wait for the symptoms to get bad, but to start the medications as soon as you have the mildest symptoms begin, and that may help. Particularly with the so-called the steroid medications. Also, it suggests that in your house you should have ventilators and other things that air filtrators that can purify the air in your house so that you don't have allergens inside the house. And then establish a coming back into the house routine. So after you take a walk or whatever, that you come in the house, you take a shower, wash your face, put on clean clothes, and that'll help uh, take care of the pollens that you picked up while you're outside. And then strategically plan your outside time. You know that between 4 a.m. and noon might be the time that you have the lowest pollen counts. And so that's the time you should plan on going out and stay inside other times where you have your air filter in your house. And then there are immunotherapy medications that now we have that when you know you're allergic to something, you can take these uh, immune therapies to deal with some of these allergies. So those are some of the tips to uh, minimize the disruptive aspects of the season allergic season that we're right in the middle, right in the beginning of. Any comments on this article during the allergy season? Betty?
Yes, I hear you talking about the outside allergies, but I'm allergic to dust. So I sort of have my problem all the time because there's always dust in the house. So I just I take Allegra D and I try not to take it daily simply because I just don't like I'm not a medicine person, but uh I take it when my nose gets runny or whatever. But I'm dealing with mine all the time, not just during the allergy season. I'm fine outside, but the dust is what my problem is. So it's an ongoing thing year round.
Thank you for sharing. Darryl?
Yeah, I used to have allergies, and my doctor told me to take Sudafed, and it raised my blood pressure. So if you have blood pressure problems, avoid things like Sudafed. The nasal decongestants have less systemic impact.
Okay, Catherine said, welcome to Nick. Glad you could join us today. And please feel free to ask any questions or make any comments that you want to share with us. So, Catherine, thanks for inviting Nick to be with us, and we welcome him and appreciate the fact that he's joining us today. John Buchanan?
Yes, um uh, when it comes to allergies, I never had allergies my whole life until I turned 50. And it seemed like the day after I turned 50, I got allergies. And mostly grasses, pollen, things like that. But this year, uh, for like 2 straight weeks, um, I think it was allergies, um, nose running, almost constantly running,
Mm.
but no other symptoms like cough or fever or anything like sore throat. But so I'm thinking that may have been an allergic reaction to the pollen because it really exploded here in DC. Thanks.
Thank you for sharing. Yeah. Any other comments you want to share? If there are no other comments, John, you can start the articles.
Does climate change any of that? That I'm sorry, I didn't say good morning.
In terms of the uh, uh, in terms of the pollen, is that what you mean?
Yeah.
Well, it's the season for it, so uh, I don't think it matters so much. Of course, uh, I don't know that the pollen count depends upon the temperature. Anybody else want to make any comments about an answer to her question about the temperature modifying the pollen count? Looks like there's no comments. I don't have the answer. That's something that I don't have the answer to. Okay. This is an article that a sign you're taking too many vitamins, and right now most people feel that uh, uh, taking vitamins uh, rather than emphasizing eating the right foods is not necessarily the way to go. And there are toxic manifestations of vitamin C, magnesium, and almost any vitamin you can over overdo if you most of the studies suggest that other than vitamin D, uh, uh, which 2,000 international units recommended, uh, uh, that uh, not very much really there's not a role for taking too many vitamins unless you have a test done that demonstrate that you're vitamin deficient, in which case there's a good reason. But here's what they say are can be signs of taking too many vitamins, although I think that's unusual. The heart palpitations or chest pain, usually that's a cardiac symptom, skin irritation, uh, discolored urine and skin, dizziness, and I guess for those people who take a lot of vitamins, they may have these things. I don't know how many of you take vitamins other than vitamin D or vitamin C, uh, but these are some of the signs that you may be taking too much vitamins. But I think that one of the most important things to do is to have tests for vitamin deficiencies. And if you have a vitamin deficiency, then you might take vitamins. But taking multivitamin pills on a daily basis, usually one or two is not going to be harmful, but those people who take more than one or two may have these problems. I haven't encountered many patients who have the toxicity from the vitamins. Uh, uh, Darryl, you had made a comment about the climate. Did you want to share that with everyone?
Yeah, this is just an internet search. It says temperature has a significant effect on pollen count. Warmer temperatures generally increase pollen production, leading to higher counts and longer, more intense allergy seasons. Conversely, a sharp drop in temperature can halt or reduce pollen release, while high temperatures can make pollen more potent, triggering worse allergic symptoms.
Thank you for sharing. I hope, Catherine, that answers your question.
It does. Thank you.
John Buchanan?
Yes, one thing I've been doing every time I have my physical, every time I see my my primary physician, I bring all of my medication, not just the vitamins, but any supplements that I take on a daily basis. I take all of them with me to the appointment and show them to the doctor so he can update my records. And he recommends that, and I think it's very important to do that. Thanks.
Thank you for sharing. Okay. All right. Let's go to the next article then. This is an article that kind of decries the situation with the CDC, in which we really don't know for sure whether or not we have no longer a country that is free of measles. Of course, we know we aren't, but uh, in order to really study it, you have to look at all of the cases of measles and look at the genomic aspect of it. And this has not yet been done, but it's in the process of being done. And so uh, sometime by the end of this month, we should know whether we are free of the measles or not. Of course, it's the data that we have suggests that we are no longer free of measles, but and still the measles vaccine, taking two shots are enough to vaccinate you against measles. But up until this year, we had been free of measles. But of course, because of the number of people who've not va been vaccinated, measles has crept back into the fray, and so we're going to have to really undergo genomic testing to see if we're still measles free. And so that's what this article is all about. That the new secretary, which is with his efforts to decrease vaccinations, uh, is under constant criticism because of that. Any comments on the uh, state of affairs with vaccines in the United States? Well, we await the genomic analysis, uh, um, but the numbers suggest that we we have a vaccination situation that may open the door for measles and other viruses. Dr. Press?
We have to vote.
Yeah, did you hear Trump crying about the fact that if we don't vote, all of our efforts will be in vain? Well, uh, we need to vote the Republicans out out of the so that we can uh, get back into where we were because we've lost a lot of ground.
The 25th Amendment.
Which one is that, Liz?
To get rid of the incompetent president.
Yeah. That's the 25th Amendment. Huh? uh, uh, okay. All right. Let's go to the next article, please. Yeah, well, this is a very good article that talks about bacterial Haemophilus influenza that is likely to return because it's here again, it's preventable by a vaccine, and the number of people who are getting the vaccine is decreasing. And just as the measles is increasing, so is Haemophilus influenza, bacterial infection, which causes meningitis and brain damage and many other problems, and as including death. And here again is one of the consequences of not of decrying being vaccinated. The number of this article identifies that the number of patients who are being vaccinated and is decreased, and the number of patients who are getting meningitis and dying from Haemophilus influenza is increasing. And uh, this is another disease that is preventable by vaccine. So this is an important article to keep in mind in view of what's happening in the United States today. Any comments about the fact that vaccinations have played a great role in preventing disease? An ounce of prevention is worth a pound of cure. And so when you have somebody in power who decries vaccinations, then the price that the country pays is a very expensive one, with people dying and people getting sick and being debilitated. As some of you have indicated, some of our children and grandchildren are reluctant to be vaccinated, and that's the price that the country will pay for that disinterest in being vaccinated. Any other comments on this lamentable situation we find ourselves in? So the need to change uh, is that it should be evident. Any other comments about this price we're paying for uh, not being vaccinated? Okay, if there's no comments, we'll go to the next article. This is an article that points out that far too often cancer specialists uh, treat patients uh, in a fashion that is not exactly what they want. Very often patients want to have, or they value quality of life over length of life. And what they're suggesting by this article is that the oncologists and cancer specialists emphasizing and preserving the lives of patients over the importance of the quality of the life that they live. And so this study is demonstrating that the alignment between what the patients want who have cancer and the treatment they get is not consistent. And since autonomy and doing what the patient wants is prime in taking care of patients, uh, patients should be given what they want. If they want to have quality life over a length of life, that's their prerogative. And the autonomy of the patient should be preserved at all costs. And that's what this article is suggesting. That sometimes we're so anxious to cure patients that we expose them to complications that are worse than the disease itself. Any comments on this? You may have some friends who have cancer who have been. John Buchanan?
Yeah, exactly that, Dr. Callender. I've just heard several times in the last couple of weeks, really, when some of my friends or their relatives or friends have had cancer treatment with the chemotherapy and the radiation. They lose their hair, and they're in pain, they're weak, and they really complain about it. So yeah, I think this is an important thing to have the doctors, monitor the patients for their wishes. What do you want to do? Do you want to lose all your hair? Do you want to have this pain? You want to have nausea? Do you want to have all these other negative effects? And with the possibility of getting rid of the cancer. So I think it's definitely a valid argument there. Thanks.
Well, I think what is most important is that the patients be given the option, that they're given all the facts, and then they make that decision. And whatever decision they make, the doctor should go along with it because that's what really matters. But so informed consent and the autonomy of the patient making the decision, because one of the things that some of the complications, for example, people who lose their hair from the medications, it invariably will grow back in time. So the question is, do you want to lose your hair for a short time and save your life, or but these are decisions that the patient should be making, not the doctor. So your point is well taken. Thank you for sharing. Darryl?
Yeah, I got a lot because I'm in my 70s. I have friends that are also in their 70s, and about 70% of men over age 70 have some cancer cells in their prostate glands. And so a lot of my friends are getting diagnosed with cancer, and they have to make that decision of treatment versus quality of life. And some of my friends, the cancer is slow growing, and the doctors will tell them that uh, it has to be monitored. But if it stays slow growing, uh, they could live with that cancer for 10, 15 years. If they're in their 70s, that means they're going to be close to 90 years old, which means that they'll die of something else before the prostate cancer. Um, some of the treatment can really impact quality of life. So, it's really important conversations that men have to have about treatment versus quality of life.
Thank you for sharing. Dr. Perez?
I'm glad you said discussions because I think often it's also a family decision. I mean, the decision is ultimately the patient's, but there are discussions that they need to have with their advocates. Because I know when I'm in pain, That's not when I can advocate for myself. And sometimes the pain really is a temporary moment. And when we are mature enough to have these discussions in our right mind with our people, I think it's important. And recently, I've had to do that with some friends and family members who have transitioned. And, it's like a big grown up conversation. But we need to have it.
Right. And the best time to have it is uh, before you uh, get really sick and have all that pain. Because, as you said, that distorts your perspective completely. And so, talking about advanced directives becomes an important thing to do, not after you get the pain and everything, but actually while you're comfortable. And so I think April 16th is the day of decision day in which everyone is encouraged to make a decision about the advanced directives and what they want and do not want should anything happen to them. And the time to do that is the time when you're well and of sound mind, not after you actually are sick. But uh, anyway, it's food for thought in terms of that. And thank you for sharing. Any other comments about this very important topic? Okay, well, let's go to the next article then. This is an interesting article because I remember last time we talked about LPAs. And this article, what's different about LPA, which is different from the other cholesterol levels, is that you really don't need to get it more than once or twice because it is what it is. Unlike the HDL and the LDL, which vary a lot from time to time and depending upon diet and the like, the LPA is pretty much the same once you uh, get it done. So you only need to get it done once or twice, and after that, you don't need to follow because what you need to do is once you find you have a elevated LPA, is to treat it like you would treat the elevated LDL or HDL. So, and this article points out that unlike those, the LPA, once you get it done, is uh, once or twice is enough to get it done, and you don't have to monitor it all the time. But most of us never get it done, so it's important to add that to the list of things that you'd like to get done, because it does have an impact upon the development of arteriosclerosis and cardiovascular disease, heart attacks, and stroke. Any comments or any response to what this article is talking about with the LPA, which we talked about last week, but I thought it was important to demonstrate that it's a test that is a value, but it doesn't need to be done more than once or twice in your lifetime. Okay, I don't know anybody who's gotten LPA recently, but it's food for thought. And it's treated the same way as you treat the hypercholesterol levels with statins and cholesterol level lowering medications. Okay, let's go to the next article if there's no comments on that one. And this is an article that goes into detail about the HDL and the LDL uh, and what you should do about them when the levels are. They emphasize that when your LDL is above 100, uh, that's a concern and needs to be treated. And if it's particularly if you have a high risk, if you have hypertension and other complications. Uh, Whereas if the LDL is 75 or 50, then it's not as important. And the HDL similarly. So, except they're saying that you don't really have to have a very high HDL because the HDL is theoretically protective and the LDL is more destructive and is more associated with arteriosclerosis, which is the offending agent which leads to coronary artery disease and stroke and heart attack. Yeah. So, any comments about the triglycerides as well? If you have triglycerides, which is more than 175, then that's a great risk factor, which is treated the same way as the high cholesterol levels. So HDL, LDL, LPA, and triglycerides, they all are numbers that you should know about yourself in terms, particularly as you get over 60. So just like you know your blood sugar and your blood pressure, you need to know your cholesterol levels as well. Okay, any comments or questions about the importance of cholesterol levels as you age? Okay, let's go to the next article then. Finally, this is an article that is attractive to see that the EPA is now targeting microplastics and drugs in drinking water. Uh, One of the things that we have lamented for the past year or two is the fact that we haven't really talked about how do we decrease the microplastics in our bodies since everyone has them in all organs and tissues. And we talked about many other things, but not ways of decreasing the microplastic levels, which are saturated in most human beings. And so finally, the EPA is now targeting drinking waters and looking at microplastic levels and looking at other ways to decrease the microplastic levels, which are far too high and associated with many of the chronic diseases that we have. Any comments about this very important uh, recognition that the administration is uh, finally addressing ways to reduce the microplastics in our bodies? Some would argue it's too much too late, but better late than never. Any other comments about that? Phil, you had a comment? Anybody else have any comments about it? Because this is a topic that has been under recognized and under addressed.
I guess my question, this is me, Catherine. I was wondering, we put things in, at least I do, put things in the microwave that have plastic sometimes. And I've often wondered if that's an issue
It
with
is.
this.
It is an issue. It is and I think they've identified that as an issue, just as you mentioned, and that we need to do that, that the microplastics get into the food. So, and that's just one of the ways in which microplastics affects us. John Buchanan?
Yeah, as a result of these uh, awarenesses, I store a lot of my leftovers in plastic containers in the refrigerator, but I've stopped heating them, reheating them in the microwave in the plastic container. I'll put them in a porcelain or glass container to put them in the microwave as a result, because the microwave, um, if you look at some of those plastics, if you cook with them before in the microwave, they bubble up, So I know that the chemical structure of the plastic changes under the microwave. Thanks.
Thank you for sharing, Darryl.
Yeah, it's not only heat. Heat um, creates the most leaching of plastics into food, but like you can have a cold drinking water bottle, and you get microplastics from that as well. So, I don't drink the bottled water anymore. When I store food, I store it in glass Pyrex containers. I just try to eliminate use of plastics in food altogether.
Thank you for sharing. Any other comments for this very important? Betty?
Yes, I like Darryl. I try not to use plastics, but uh I buy paper plates and for my microwave. I I use paper plates when I'm heating things in the microwave. But I'm wondering now whether down the line it's gonna be something wrong with paper. But
Well, we never know, but we do know that we have it with plastic. So,
the
at least
plastics,
for the time being, that's the right thing to do.
yeah.
Janice?
Yes, I agree with Betty. I do use plastics, but generally it's just to store food in the refrigerator. But we've had so many conversations in our sessions that it has made me nervous. And I don't heat my food any longer in the microwave with plastics. I use paper plates for the most part. But, everything comes with change. But in doing that, I'm like Betty. Will the plates be an issue? It seems to be a cycle. Things we've been doing without thinking about it, most of them are no longer good. So, I mean, day to day, I guess we have to live and learn. But I am trying to make change.
Thank you for sharing, Darryl.
Mhm.
You know, I use ceramic or porcelain, china, whatever you call it, the
Mhm.
hard plates and microwaves.
Mhm.
Um, because paper plates, this is just from the internet. Many conventional paper plates are coated with a thin layer of plastic,
Mhm.
typically
True.
polyethylene or wax to make them water or grease resistant. This coating often makes them non recyclable and hard to compost. Some paper plates also contain PFAS, known as forever chemicals, to enhance grease resistance.
There you go. I think for me, I've gone from plastics to paper. And as I said eventually that won't be good for me. But I also do it because of convenience. If I use the glass or porcelain, I've got to wash dishes. And that adds to my dish load.
Uh,
So I'll think about it,
okay.
Darryl.
Okay. Any other comments? Thank you for sharing all of those important things. It's amazing. This is such a good way of educating the community about all of the health issues that crop up, and by being aware of these things, we can encourage our our health practices to be the best that they can be. So I think this is a good start. So, okay, any other comments as we move on? Catherine?
I was gonna say, I think I got in the habit of doing that with the plastic because the containers they give you from the restaurants when you're, have leftovers or something, they have the vents and everything in there for you to be able to just stick it in the microwave. And I need to stop doing that. I don't always do it, but I do for sometimes with things that came from a restaurant. So that is a bad habit I have to break.
Thank you for sharing, Catherine. Okay.
And also, some of those containers say on the bottom, microwave safe. The plastic containers I'm talking about.
Yes, they do.
Okay. All right. Let's go
Um,
to the next article. Huh? This is a very interesting article. It dovetails into some of the things that Darryl was talking about with prostate cancer. One of the things that is happening now is that getting an MRI of the prostate uh, allows the uh, surgeons and the cancer specialists who treat prostate cancer to make prognostic determinations on the extent to which the cancer is controlled or uncontrolled, and to decide what kind of treatment is best. And so that getting an MRI of the prostate now is a test that is invariably done. In the old days, all we did was do a rectal examination with your finger. Now we do the MRI to look at the prostate and determine the extent to which the prostate the cancer is limited to the prostate, has gone to the outside of the prostate. Catherine, you had a comment. Oh, did you? Well, your hand was up. I thought that you had a comment. Okay. All right. But anyway, so this is the newest way in which we uh, find to get a determination as to whether the prostate cancer is limited to the gland itself, or it's going to the seminal vesicles, or going outside of the gland, going to the lymph node, other areas. Dr. Perez?
That should be good news for men to
It is.
go and, we should talk this up, get our brothers to go and see a doctor, knowing they're not going to get a digital exam.
Well, that is the latest trend that urologists now will get the MRI, and uh, whether or not this will encourage others to go to the doctor, I don't know, but certainly this is the state of the art now. Just as we talked about going from plastic to paper to we've gone from a rectal examination to an MRI of the prostate. Dr. Perez, well, let's see. John Buchanan.
Yeah, I'm pretty sure though the finger exam is a lot cheaper than the MRI exam.
It's cheaper, but it is certainly not as definitive in terms of identifying whether or not the cancer is going outside of the prostate gland, because the finger can't tell that, but the MRI can.
And as a follow-up, how much do MRIs like that cost?
I don't know exactly what they cost. I know that most insurances will cover them, but I do not know the cost for the MRI. Darryl?
Okay, what's the cheapest yet? is before you get to a PSA number of 4, where they're considering doing the MRI, and if that shows, depending on what that shows, they may want a biopsy, which is they enter through the rectum generally for the prostate biopsy, and that can be painful, very stressful, particularly when you're bleeding from the rectum into penis for a week after that. Along the way to 4, uh, the PSA is going to be at 2, at 3. That shows that you're on your way to possible prostate cancer. And that's the time for diet changes. There are some doctors that say that doesn't matter what you eat, but cancer is something that you go more with a plant-based diet, stay away from inflammatory foods. You have a chance of holding your PSA down, and so that you're not on that path. It's not always just eventual. It's not always a certainty that all men are going to suffer and have a terrible quality of the end part of their life because of prostate cancer.
Well, the one thing that the MRI does is that the MRI can look at the prostate and identify whether it is only in the prostate or just beyond the prostate, or whether it's cancer or not, and whether or not you need a biopsy or not. And so that's the role that the MRI will play as well. Catherine, you indicated that somebody was on it that for the first time again.
Yes, Philomena is Phil on there.
Oh, that's who Phil is. Okay. Well, welcome. We're glad to have you. And feel free to ask questions anytime.
Thank
Right.
you very much. I'm enjoying learning all this new information.
We're so glad that you joined us and hope you'll continue to. Uh, okay. Any other comments about this great article that talks about it? And thank you for your information you shared with us, Darryl. Okay. So let's go to the next article. Yeah, this is an interesting article that says you now can get a urine test for bacteria result in 6 hours compared to the 2 to 3 days that it took before you could get a culture result back. So this would be a tremendous breakthrough for the treatment of urinary tract infections, which is one of the commonest infections that we have. And so there's no detail in this article, John Buchanan, already to tell us how much it costs. But it's a test that's going to be worth its while if you can get a result in 6 hours rather than 3 days, 2 to 3 days, because that means you can start the treatment for the infection the same day, and know that it'll be effective rather than waiting 2 to 3 days to know whether or not you put them on the right antibiotic. So this is a major breakthrough. When it will be available is the question, and how much it will cost when it's available. As you notice, this was built in UK, so how it will be manifest here in the United States and when is another question. John Buchanan?
Yes, Dr. Callender, this was one of the most difficult problems in nursing homes, the UTIs. Can you elaborate on, what's going on with them, and why they're so problematic? They cause a lot of issues with the elderly.
I'm not understanding your question.
It just seems that when elderly people have UTIs and they're in nursing homes, things like that, it's more than just an infection. They have physiological changes. They have even psychological changes that result from UTIs. Do you know anything about those?
Well, if you have just a simple urinary tract infection, then and you're able to treat it rapidly, then you won't get what when you get septicemia, which means that it's gone from the urine and it's gotten into the bloodstream. Then you have manifestations of uh, psychological and other changes. But if it can be diagnosed early and treated early, and sepsis is avoided, then the side effects that you mentioned are avoided. But this new test that they're talking about, if the nursing home is becomes gets has it available, would allow them to make an early diagnosis of urinary tract infection before septicemia and other consequences can develop, which would cause the problems that you're talking about. Because a simple UTI that does not have uh, septicemia or blood poisoning with it will not, and it's treated early, it will avoid the side effects which you mentioned. But you're absolutely correct that this is a common problem in nursing homes in terms of getting a UTI and not making the diagnosis until very late. And at that point, they have septicemia, which is getting the infection in the bloodstream, which then affects the brain and other areas.
And what are some of the symptoms of UTIs before it gets to that
Oh,
sepsis?
usually, well, often you'll have burning upon urination, or you'll have cloudy urine. The earliest sign may be cloudy urine. A later sign might be burning when you urinate. Uh, and a simple urinalysis usually will give you an idea because you'll have white cells in the urine. And then you get a urine culture, which traditionally takes 2 to 3 days. That has been maybe the problem in terms of them in a nursing home, waiting for that result to start the appropriate antibiotics and prevent the septicemia, which actually causes the signs and symptoms that you talked about. Any other comments or questions about UTI, which is uh, common in men and women, but perhaps more so in men. Any other comments about this important article? So time will tell when it'll become available here in the United States and what price you have to pay for a test that gives you a result in 6 hours rather than 3 days, which would make a big difference in the recovery of a patient. Okay, the next article, please. This is an interesting article because we don't really have many acid blockers uh, to use with clopidogrel. The PPIs which we do use for GERDs and gastroesophageal reflux uh, are what we usually use, but the uh, potassium competitive acid blockers we don't tend not to use. Although some would argue that those PCABs that they talk about are more effective and longer lasting than the PPIs, but the PPIs are not as associated uh, uh, with the complications, the medical complications that you have with the potassium uh, gastric esophageal reflex medications. So we tend not to use those here in the United States, and we tend to use the PPIs, which are not as associated with the medical complications as the medication they're talking about here. So that's why this article is published in outside of the United States, because we don't use many of these drugs here. And the stroke risk that they talk about was found predominantly with the potassium competitive inhibitors. Any comments or questions about that? It's not as applicable to us here in the United States because we aren't using those drugs, although PPIs are the ones that we use for the most part. Okay, and I think more recently there have been articles that have indicated that the PPIs, even when they're used for long term, uh, don't have uh, as many risks as we thought it had initially. As many of the PPI users have changed after a year or two. They use different medications, and the long-term studies are demonstrating that they're not as toxic as we thought they were before. This is an article that talks about Medicare wellness visits, which uh, we know about the annual visit, which some of you have described as problematic, and some of you have indicated that some of these visits, they don't even examine you. So this has an article talking about what to expect from your annual visit, and I think it is expected that you would be examined in your annual wellness visit. Uh, whether or not your doctor is doing it or not, the annual wellness visit is supposed to be a visit in which they, as John talks about, he does it in the right way. He gets his blood results first, uh, then goes to the doctor. The doctor then examines you and finds out whether you're okay or not. And it should not be uh, a visit in which you talk with the doctor and there's no physical exam. It should be an exam, a situation in which uh, you have a physical exam as well as a wellness check. Um, the question really is, what will they pay for it? And sometimes, and they point out the point that John Buchanan emphasizes, that you should take your medications, all of your medication with you, so they can make sure that you're on the appropriate medications, because things may have changed, and maybe you don't need to be on as many medications as you used to be on. And so uh, now, one of the things about the blood pressure check is that there's so many ways in which the blood pressure is checked inappropriately at the doctor's office, that uh, the blood pressure and cholesterol and diabetic check and the other screenings that you have are all important, and to follow up to make sure that you're on target. Any comment, Darryl?
Yeah, when I go in for my wellness check, the nurse does a great job of taking a blood pressure reading. She makes sure that uh, the arm where the cuff is at heart level, that my arm is resting on something, that my feet are flat on the floor. And her blood pressure readings generally agree with the readings that I take at home. Then the doctor comes in and he does it. And he does it where my arm is not resting on anything. The cuff is not at heart level. I'm sitting on the little bed, and so my feet aren't exactly flat on the floor. And he gets a different reading, but he's more, he relies on the reading that I'm taking. I bring in my readings from home, and so he says you're okay. But I want to tell him that he does a terrible job of checking blood pressure. But I'm not going to make him an enemy because he's my doctor. So I just keep my mouth shut and keep on stepping.
Thank you for sharing. Janice?
Yes, when I go in for my physical with my doctor, I think he's very thorough. Not only does he do the physical checks and look for swelling of ankles, and he always revisit the last visit, have this change, have that changed. He reminds me of appointments that I should have had in between the visits, and he has the results, but he also talks about the results of those other visits. Something he's done the past couple of years is a memory check. He'll say 3 words. Now, later on, I'm going to ask you about those words and see if you can remember them. And that's good. And it does keep me on my toes and help me to think clearly what he said earlier in our conversation. And he will also show me 3 different drawings of lines, octagons, or whatever different shapes, and ask me if I can duplicate it, then I would have to draw those 3 pictures. So I think my physicals are pretty thorough, and I think they
Wow.
are geared towards seniors.
Yeah, that's excellent.
Yeah,
Yeah, you're a good doctor.
yeah. Mhm.
Yeah. Okay, any other comments? Because this is one of the things that many of you have complained about in the past in terms of not getting good annual visits. Carol, Tatum?
I just went for my physical, just 2 points. He's trying to persuade me. He said that everybody that has part, I think B, can get this blood pressure monitor where he wants to monitor himself instead of you monitor. So when you take it, it goes straight to the office and he can monitor whether or not he should adjust your blood pressure medicine and etc. And I was trying to pinpoint him at what time of the day should you do it. He said you definitely don't do it when you first get up in the morning. And then he was saying something like middle of the day, but I was trying to figure out so I could do it regularly. I'm the person I have to create a habit. I have to do it that's most conducive that I'll do every day. Then I was wondering, do doctors have to touch you anymore? I mean, besides touching your neck and listening to your heart, I mean, the exam is just mostly just talking. So it's two
Exam is
points.
not
Huh?
exam is not talking.
So you touch the person?
Yeah, exam means that you touch the patient. Yes.
Okay. It seems like there's very little touching. I don't know if anybody else is there, besides my neck and my throat and listen to my heart and then maybe glance at my feet. I don't know what else he's supposed to do. And then he might touch my stomach. I guess it's not that much more to touch, huh?
Yeah, well, I mean, he's examining you, it sounds like, but uh, the extent to which he's examining you may be the question. But it sounds in some examination that we've heard about that they don't touch you at all. So, but the expectation is history and physical examination are part of a wellness checkup.
Oh, okay. Because they used to a long time ago give you tap on your knee is to see about your reaction and all that. But that hasn't been done to me. Anybody else is getting that? When you get, your elbow or your knee with a hammer or something, see your reaction.
Not in years.
Yeah, mine will touch.
Well,
Uh,
you all remember that I said one year I had my physical exam on the telephone.
It's funny.
That's lamentable. Yeah.
And if anybody else, doctor, trying to sell them on this blood pressure a blood pressure cuff that they can monitor, they said everybody that is on Medicare can get it. And it's free. They give you a blood pressure cuff. You take your blood pressure and it goes straight to your doctor's office.
Where's that?
Um, he had one for John. I turned it in, and now he's trying to sell me on it. I'm going to do it as soon as I figure out what's the best time of the day to do it and get myself in a habit. So when I start doing it, it'll be right. So still don't know what's the best time of the day to take your blood pressure. But he said
Probably,
it's available.
probably, probably about a half an hour to an hour after you get up, or it's actually you can decide to do it any time of the day, but you should do it the same time uh, every day if you're going to do it once a day. Uh, uh, but I think probably half an hour to an hour after you wake up, or maybe midday. Uh, I know I do mine actually in the afternoon, but so far I haven't seen any article that identifies a specific time that you should take your blood pressure. So it's just clear that you should take it and record it as Darryl mentioned, and then take your readings to the doctor so he can see what they are. Darryl,
Yeah, this is just off the internet. The question was, when is the best time of day to take your blood pressure? It says the best time to take blood pressure is twice daily, in the morning before eating or taking medications, and in the evening before bed. Consistency is essential, so take readings at the same time each day, preferably after resting for 5 minutes, ensuring your bladder is empty, and avoiding caffeine smoking 30 minutes prior. Uh, Key tips: take readings once in the morning before breakfast and meds, and once in the evening. Consistency is a key. Do not take your reading immediately upon waking up. Wait until you have dressed. Preparation: empty your bladder, sit quietly, avoid exercising, smoking, or consuming caffeine 30 minutes before testing. Double check. I like this one. Take 2 to 3 readings about 1 minute apart for the most accurate average. I find that uh, I take 3 readings when I take it. Uh, Numbers readings 2 and 3 agree. So I like readings 2 or 3. Those are the ones that I enter in my log. And record everything, document the date, time, and blood pressure reading to share with your doctor. I also put my heart rate in there uh, because, I get familiar with my heart rate. It shows like when I'm truly resting. So like for me, a resting heart rate is uh, is around 55. If I take if I get a reading that's at 60, 62 for me, I really haven't rested, but I'm a resting heart rate at 55. So you want to get your blood pressure reading, whatever your comfortable resting heart rate is.
I think that's good advice. Good advice. Makes sense. Yeah. Okay. Any other comments? That's a very important discussion we just had. Okay, let's go to the next article. Um, this is something that I've been aware of for quite some time, except that I've always felt that we should start taking blood pressures at the age of 10, 11, or 12. But because people of color uh, have higher blood pressures at a younger age, and the consequences. Uh, they talk about midlife, actually. Uh, Very often the blood pressure is already elevated by the time you're 20. So the earlier you start taking it, the better. So you can, and if you have hypertension, if it's not treated, then the likelihood of the consequences of kidney disease, heart disease, a stroke, and the like are very common. And this article talks about the price you pay for neglecting to treat hypertension. Uh, and of course, there's a lot of discussion about what is the best blood pressure. Debates range about whether it's 120 over 80 or lower. But most will agree that if it's between 130 over 80 and lower, that's okay. And if it's above that, then uh, some efforts are needed to keep it at a level that is no higher than 130 over 80. Because most of the studies indicate that the lower the blood pressure is, the better off you are for the most part, assuming that your blood pressure is not less than 90 or 90 to 100 over 60. Uh, and uh, so I'm saying you shouldn't wait until you're 20 to get your blood pressure checked. The sooner the better, particularly for people of color. And if you have hypertension, then it needs to be regulated. And the reason cardiovascular disease is the number one cause of death is because most people who have hypertension are not treating it properly. And many of them don't even have a blood pressure apparatus to take the blood pressure at home. So they're not controlled. And if it's not controlled, then you've defeated the purpose of finding out that you have high blood pressure in the first place, because the goal is to manage it and keep it under control. Any comments about this? Because this is very important, as important as anything else we've discussed today. Is everyone having a blood pressure apparatus and taking your blood pressure at home, keeping a record of it, and sharing it with your primary care doctor. Yes, Cal?
Yeah, blood pressure is definitely related to weight and obesity. Uh, the heavier you are, the greater chance of blood pressure. In the United States, um, highest among obesity is highest among non-Hispanic blacks and Hispanic adults, with obesity rates of 45%. Compared to 41% of white adults and 16.1% of Asian adults. Um, and black women have the highest prevalence of over 56%.
That's
So,
it.
we've got not only a hypertension epidemic in our demographic, but also an obesity epidemic that we have to deal with because they're both related. And the thing to keep in mind, if you go to other countries, they can spot Americans, whether doesn't matter, white, black, whatever. They can spot Americans because we're the fat ones. And we stand out all over the world. We're fatter than everybody else. But the gold standard, who's getting it done right, even because Asian Americans, they say we have this standard American diet, which is unhealthy and it causes obesity. But the Asian adults, they're doing well, including the kids. They're at 16.1%. So it's not a given that just living in America makes you fat. It's drinking the Kool-Aid in America that makes you fat. That thinks that you got to eat out all the time. Asian Americans are much more likely to prepare their own food. They eat out far less than other groups in America. And we've got to stop drinking the Kool-Aid. This convenience thing, um, we like it fast. We don't want to cook anymore. It's killing us.
Thank you for sharing, Darryl. Any other comments? Well, that's one thing that's good is that we tell the truth. So, like it or not, right? Okay, we have. I guess we may have. Let me see. We may have time for one more article, perhaps. Yeah, this is the article, and lifestyle is tied to cardiometabolic risk, which kind of what Darryl just finished talking about. And what we started off the program talking about in terms of sleeping, exercising, and eating, all lifestyle becomes critical if you have hypertension, uh, because that's the number one killer. Cardiovascular disease is the number one killer in the world, and especially in the United States, where we have we're less healthy than most other, well, all other developed countries, as Darryl has appropriately identified. And our life expectancy is lower than most of the other developed countries, primarily because of the two factors that Darryl mentioned, the obesity and hypertension, cardiovascular diseases. Okay, if there are no other comments, I guess this is the last article, and thank you all for attending. Um, thank you for Phil for joining us, and hope you come back again. And